Well, welcome everyone to the Here for the Girls third annual In the Know. It is, however, our second where we have brought together all the experts and the physicians from different healthcare systems. And for us, this is a great thing for the community. It sends everyone, the message that we're all in this together, and that's a wonderful thing. We're grateful for everyone that is joining us this evening. Our discussion regarding the latest in cancer care and research will offer each in the know expert the opportunity to share their insights, and it will be followed by a Q&A. Joining us this evening is Ann Kiernan. She is one of our 2023 calendar ambassadors, and she will be our moderator for the evening. Thank you, Ann, for taking on this role. Before we introduce tonight's panelists, what I wanted to let everyone know is that this is being recorded, and the information presented in tonight's live Q&A and is for educational purposes only. For answers to specific healthcare questions and concerns, we ask you to please consult your healthcare provider. I'm just going to do the run through quickly, and then when Ann introduces each panelist, she's going to give a little bit more of a background. So tonight we have joining us Dr. Eileen Steffen from Riverside Health, Dr. Sonia Hepburn from Virginia Oncology Associates, Sarah Pass from Myriad Genetics, Dr. Mary Helen Hackney from VCU Massey Comprehensive Cancer Center, Dr. Jason Wilson from Sentara Health, and joining us a little bit late, he is actually with a patient this time. It will be Dr. Eric Jablanca from North Beach Plastic Surgery. Ann, I'm going to turn it over to you.
All right, we're going to kick it off with Dr. Eileen Steffen. She is an oncologist and hematologist. Oh, she is the Riverside physician at Riverside, director.
I do the survivorship.
Survivorship. I'm sorry, I started on the wrong line. Directing survivorship for Riverside Health System, radiation oncology department, and cares for patients' life after cancer. Our discussion today with you focuses on empowered health at any age. Could you share a little bit more information regarding what empowered health is and why it's crucial to overall well-being following a diagnosis?
Sure. Thanks for having me. Good evening. Empowered health is the concept that patients can and should be actively engaged in their healthcare decisions. And, the basis for that is really education about cancer patients' diagnosis, treatment decisions, and in that way they can, become shared participants, shared decision-making with their healthcare team. And they really are the critical part of the healthcare team. I think that this is so critically important because a patient who's engaged is much more likely to adhere to their treatment plan, to follow up with surveillance recommendations and follow up after treatment, which is my role. And in addition, I think it gives patients a sense of control in a situation and a diagnosis that's so hard to cope with mentally and physically. And I think that's incredibly helpful to have a sense that you are taking charge of your own healthcare.
Yeah, that's really poignant for my story. I found my own tumor when I was 36 and 6 months pregnant.
Right.
Could you now discuss the importance of self-awareness regarding bodily changes, not just from breast cancer, but also discuss how to effectively communicate those changes?
Absolutely. Well, you've experienced that firsthand. So, as healthcare providers, a lot of what we do is listen to what patients are experiencing, and that's how the diagnosis is made. It's often a patient bringing a concern to us that prompts the evaluation and ultimate diagnosis. And, the earlier those concerns are brought to us, the earlier the diagnosis can occur. So it's really critically important to be aware of those changes. And I think in terms of effectively communicating them, being as direct and specific as possible. Sometimes it's a scary change that you're noting, and patients can sometimes have the tendency, and I myself included, of wanting to stick your head in the sand, but being very direct and forthcoming about what's going on. Trying to provide a pretty clear timeline of the change is really helpful for the provider. And for patients who have a lot of other medical issues, I think sometimes their new concerns can get lost in the shuffle of, kind of managing their other diagnoses. So if you're in that situation and you feel like it's being overlooked, I think making an appointment with your provider just to address that specific change or concern is important and helpful.
Very good. Can you provide some information regarding knowledge related to one's risk of cancer and characteristics or behaviors that may increase the overall risk, and what is and is not actually in our control?
All right. Um, so, I think just we're discussing that empowerment piece with your healthcare. So knowing your risk factors, seeking out your family history, for instance, is important because it allows you to be proactive in seeking out the screening associated with the diagnoses you may be at risk for. Um, it helps you be more vigilant about any new symptoms or problems that come up and bringing that to attention. For instance, if you've got a strong family history of colon cancer and you have changes in bowel function, then you're more apt to seek medical attention early. So I think that knowing those risk factors can be really, really helpful for patients who can access that information. And there's a lot that's not in our control. You can't control your family history. You can't control your age. You can't control, early menarche and late menopause in the instance of breast cancer. But there are modifiable lifestyle changes that you can make. You can maintain a healthy body weight, a good nutrition, a diet that's high in vegetables, fruits, lower in animal fats. Um, Things like reducing your alcohol intake, which more and more is being recognized as a risk factor for breast cancer. Um, Stopping smoking if you're a smoker. So there are a lot of risk factors that are modifiable. And again, if you're at risk for a particular cancer, you discuss with your provider about what are you doing in your day-to-day life that could be changed in order to help reduce that risk.
Awesome. Well, thank you, Dr. Stefan, and we'll come back. I already have a few questions in my head for you. We'll come back to you.
Good.
Building from what Dr. Stefan said, I'm going to introduce Sonia Hepburn now from VOA, my oncologist of practice. She's an oncologist and hematologist, and she serves on the Here for the Girls Board of Directors and continues to offer breast health education to better the lives of our community. Welcome, Dr. Sonia Hepburn.
Thank you.
As our discussion today focuses on the unique experiences of those facing a cancer diagnosis, could you discuss an individualized approach to facing a cancer diagnosis, including the unique circumstances and experiences around one's decisions regarding surgical options?
Sure. So whenever someone gets initially diagnosed with a breast cancer, we always try to start with understanding their stage and their receptor status first to try to then individualize their care. So stage being 1, 2, 3, and 4, 1 being that it's localized to the breast, 4 that it's now spread to other organ systems. And then with markers, what I mean by that is estrogen, progesterone, and HER2. HER2 is a marker on the breast tumor that, if present, means that it proliferates more, it replicates more, it's more aggressive. And so understanding that first piece of information, knowing the stage and the receptor status, helps us kind of guide which way and how aggressive we're going to be going forward. And so that's part of how we start to individualize someone's care. If they are hormone receptor positive, a little bit further down the line, one of the things that we could do to help with adjuvant treatment being any kind of treatment after surgery would be oncotype testing is one of the measures that we could do to send to see what's the likelihood of the cancer coming back. That helps us guide whether someone would benefit from chemotherapy or not. Another thing that we could do is a breast cancer index study to see does someone benefit from 5 versus 10 years of hormone therapy. I mean, I think in a lot of these cases, every single time someone comes in, we're definitely taking into account their age, the support system, all the medical comorbidities that they already have coming in. And so trying to come up together with a plan going forward. I think that for triple negative and HER2 directed cancers, if they're stage 2 or 3, we also start with chemotherapy up front and target HER2 if we can. So there are a lot of ways that we individualize those decisions. As far as going for surgery, I think that if it's an early stage breast cancer, surgery is still an option. And so one of the things that we like to know, as Dr. Stefan was mentioning, was family history. So that's very, very important to know, because if they have a strong family history, or if they're diagnosed with breast cancer before the age of 50, then they qualify for genetic testing. And that's highly important, because if by chance they carry the BRCA mutation, then we recommend bilateral mastectomy, which will completely change. It could be something where initially lumpectomy alone would have sufficed, but then we recommend bilateral mastectomy in those situations where they do carry that BRCA gene. And so knowing that genetic information up front can help with surgical planning, and then after the fact also with family risk and things like that going forward. And then for stage 4 cancers, a way that we generally tend to individualize patients' care is by sending their tumor sample for something called next generation sequencing testing, or NGS testing. It's a specific test that we could do on the tumor itself to see, did they have any mutations that then predispose them to having this type of cancer, or something that we can target directly. So more and more we're going towards personalized care, trying to individualize each patient's experience through their journey, and having these conversations is very important, especially at the very beginning.
Definitely. It sounds like a lot of complex decision making. It's probably different for every single patient that walks through your office. Could you explain how physician collaboration plays a crucial role in the development of an individual plan of care?
Sure, it's highly important. So every single time someone gets diagnosed, we also prospectively, so meaning before we even start with the treatment plan, we always talk about them at a tumor board. So at a tumor board, it's usually a combination of a variety of specialties. So usually there's physicians, there's a radiologist that read all of the MRIs and mammograms, and there's pathologists. From the doctor's side, there's surgical oncology, radiation oncology, and medical oncology. So all of us get together, we talk about each case, and then the nuances with that too. And of course, taking into account patients' preferences. Sometimes people go in and say they already know they want to do breast conservation, or they know they want to do bilateral mastectomy. So we try to take all of that into account in the decision making, but it takes a whole team of people to come up with the treatment plan. It's not just one person.
Yeah. Could you discuss the feelings of anxiety, becoming overwhelmed, loss of control, and how those feelings might impact awareness and the communication of those changes?
Yes, so I tend to find that at the very beginning, and understandably, of course, when someone gets diagnosed with a breast cancer, that's when they have the highest anxiety. This is something where they didn't plan for it. This is something that now is going to be life-changing. This is now something that's going to be with them for the rest of their life. And so I think that a lot of the times it's the highest anxiety I find is right before they have a plan. I think once we get a plan in place and they know, they can then also tell family members and their friends, and people can rally behind them. But it's getting to that stage that sometimes is the most difficult. Sometimes just even the thought of someone knows that they have a mass, but they know that if they then get the mammogram and then get the biopsy, then they'll definitively know what it is and will have to face that. So even just getting a mammogram sometimes can be very difficult. And so it's important to surround yourself by people that are going to be very supportive, to know that, you know, there's going to be a whole community of people that are going to be there for you once you get the diagnosis. It's usually a combination of social workers, palliative care workers, nurse navigators, and they're not in it alone. And this is something where, again, it takes a village to take care of these breast cancer patients. And of course, organizations like Here for the Girls is an excellent resource for all of that. So constantly amazed at all the amazing support that comes from all of these organizations. Another thing I think that sometimes during treatments can also provide a lot of anxiety. I think that it's important, as Dr. Stefan was saying, to communicate those concerns. Sometimes people start to have neuropathy, but because they feel like they need to be strong, they don't want to tell the doctor that they're having trouble. And certainly that's not what we want. We want to make sure that, you know, these are cures we want to go for, but we don't want people to end up with debilitating side effects from the treatments that we're giving. So it's just going to be very important to communicate, let us know. We don't know how to help unless they communicate, so that's going to be key.
Yeah, definitely. I could not have gotten through my treatment plan without my village. So thank you very much, Dr. Hepburn.
Sure, no problem.
Next in our panelist lineup, we have Dr. Mary Helen Hackney from Massey. She's an oncologist and hematologist, and she looks to educate on cancer screening, cancer risk reduction, and survivorship after treatment. And it takes time to be truly listened to by her patients. Welcome.
Thank you.
As our discussion today focuses, some discussion today focuses on immunotherapies. I know I hear more and more about that. Could you further define the concept of immunotherapy alongside the difference between immunotherapy and chemotherapy?
Well, I think, you know, when we think about systemic therapies for breast cancer, we look at chemotherapy, we look at immune therapy, we look at hormonal therapy. And those are three therapies that Dr. Hepburn and I are all very familiar with in terms of trying to reduce the risk of cancer coming back elsewhere in the body. Our surgeons do a great job of taking care of the breast, but it's the rest of the body we have to worry about. Immune therapy has gotten a lot of press because it sounds very easy to do in some ways. It's trying to get the body to recognize that there's a cancer cell there and to kill it. The challenge with breast cancer, it is very hard to recognize. Some cancers have proteins or substances on them that make them very easy to be recognized as being foreign and dangerous and can easily respond to immune therapies. Breast cancer is not so good with that one. Right now, the only drug that's approved that's an immune therapy for breast cancer is a drug called pembrolizumab or Keytruda. And that is an inhibitor that helps interfere with cells growing. And so when you think, there's things called checkpoints, which make sort of help prevent the immune system from killing the cancer cells. And what pembrolizumab does is it blocks those checkpoints. So it's called a checkpoint inhibitor. And so that is supposed to help kill cancer cells. The challenges right now with immune therapy, the only one that works that we know about in breast cancer is pembrolizumab. They have looked at others, they just haven't worked as well. There are lots of clinical trials out there working on it. So there's hope that we might find an immune therapy that might work against breast cancer. The other challenge that we have to remember is immune therapy is not benign. We think of immune therapies as not having, people often think, well, it's my body's immune system, I'm not going to have toxicities from it. But all of us who've taken care of patients on immune therapies will find that they can get what I call the itises, thyroid problems, rash, colitis, GI problems, pneumonitis, problems in the lungs, problems in the brain, encephalitis, heart problems, myocarditis. So immune therapies have their own challenges of side effects, but in the right situation can be a great addition, usually in addition to regular chemotherapy. The nice thing about immune therapies is they keep working even after you stop giving the drug. So they are a longer term treatment, part of the treatment plan. Chemotherapy works differently. Chemotherapy is sort of an immediate killer. And if we go back and think of our biology classes, we remember learning about cells that go through synthesis and mitosis and growth phases. Well, chemotherapy drugs work against those cells at different points. The drug Taxol, paclitaxel, works in the mitotic phase. And so that's where it kills the cells. So it's a more direct killer. And it's only going to be killing cells when people are getting those drugs. So there's not a long-term effect of them. So chemotherapy works one way, immunotherapy works one way. And then in breast cancer, we at least have to mention hormonal therapy, because there are a number of different drugs that are hormonal based and interfere with cancer cell growth, whether it be blocking the production of estrogens in the body, or whether it be interfering with where those estrogens might cause cells to grow. So those are sort of our systemic therapies that we need to think about.
Right. Could you discuss when the immunotherapy is might be recommended for patients?
Well, right now, immunotherapy for breast cancer is being recommended in triple negative breast cancers as part of their chemotherapy protocol. Like Dr. Hepburn said, sometimes we're doing chemotherapy before we go to surgery. And so pembrolizumab is added to the chemotherapy before surgery to help improve the cancer kill for these patients. And then oftentimes will be continued for a number of months after definitive surgery. So that is the main time right now that we're using immune therapy. There may be some situations where you may also add it to chemotherapy for somebody with triple negative breast cancer who's had a recurrence. But right now it's fairly narrow. Some people will have heard about something called CAR T cells, C-A-R-T cells. And that is a very novel type of immune therapy, right now only approved for leukemias and lymphomas, but they are doing some clinical trials to see if there is a way that that might work with some breast cancer patients. Again, very novel, very limited research so far, but that's a very aggressive way of taking cells out of the body, stimulating them to fight against breast cancer, and then putting them back into the body. You have to look for a clinical trial. As people are thinking about systemic therapy, I have to say that word clinical trial again. All of us have access to clinical trials. That's how we make the next step forward, is by people being willing to be on a trial. And remember that when you're on a trial, the least amount of treatment you would get would be the best you would get if you weren't on the trial. So you get good treatment, but then maybe you get good treatment plus something else. And that's how we're going to have to go forward with finding which of these drugs work and don't work.
Yeah, sounds like a intricate and ever-changing arsenal of things to fight breast
Very
cancer.
much.
Can
Very
you
much.
discuss the current and future research and trials that you're speaking of?
Oh, I think there are a number of things out there. And, one of the most recent things that came out is the use of ribociclib, which is what they call a CDK4 inhibitor, in conjunction with hormonal therapy for early stage breast cancer. That trial recently became published, and so gives us another tool that might help some patients avoid chemotherapy. A trial that was published, another drug that was approved back in, I guess, December, is using a drug called Enhertu, or deruxtecan trastuzumab, in earlier stage in certain types of recurrent breast cancer. So the evidence of trials now coming into fruition. What trials are happening right now? There are a couple of trials out there for de-escalation, where rather than doing 4 drugs for HER2 positive patients, maybe we can get by with 3 drugs. There are trials looking at how long do we continue hormonal therapy, or how long do we continue hormonal therapy plus CDK4 inhibitors. There are trials out there for new ways to approach radiation therapy, which is more local control. Let me think if I can think of my other trials right now that we have. There is a trial called BR009 where they are looking at low oncotype patients, usually ones who we don't give chemotherapy to. But maybe if we give them chemotherapy, if they're in their 30s and 40s, maybe that will give them some added chance of their cancer not coming back in the future. So there are a number of both local and national trials that are available for our patients.
Awesome. Thank you, Dr. Hackney.
Mhm.
All right, our next panelist is Sarah Pass. Sarah Pass is a medical science liaison from Myriad Genetics. On oncology at Myriad Genetics, she provides education to clinical providers surrounding hereditary cancer and precision tumor testing. Sarah, it's funny, my mom had breast cancer genetic testing 20 years ago, and when I got my cancer in 2021 and I had it, it was very different what they could test for. Could you share a little bit more about the role of genetic testing plays in both treatment and testing in relation to the family members, including when you should consider testing a family member?
Yeah, so genetic testing, as you said, has changed massively over the past 20 years, and I would even argue over the past 5 years. What we could do 5 years ago is vastly different than what we can do now. And Dr. Hepburn said this best: if you know you have a BRCA1 or 2 mutation, we know surgery choices might be different for that patient. We certainly want to make sure we're talking about them. But there are now, depending on how you want to count them, about 10 breast cancer related genes. And so knowing when someone has one of those genes can help us determine what the best treatment pathway is for them, what surgery might be best for them. Are there other treatments that might be an option for them? So along with BRCA1 and 2 helping us with surgery decisions, it's also starting to help us understand what other treatments we might want to do for them, including PARP inhibitors. And those are going to be slowly coming out as we learn more about these genes and as we start to test more and more patients to understand how that's going to help us with those treatment decisions moving forward. As we've learned more about these genes, we know that these genes are in every single cell of our body. They're going to increase the risk for other cancers as well. We don't want patients to deal with any more cancer than what they're already dealing with. So we want to be screening them for other cancers as well. So we may not change everything about their treatment right now, depending on what their plan already was, but we may include additional screening for them after they're done with that treatment for other cancers. So for BRCA1 and 2, that's ovarian cancer. For PALB2, that might be pancreatic cancer. And so we want to make sure we're screening all of these patients for those additional cancer risks that they have, depending on what gene has that change or mutation in it. As for family members and when to test them, we find that there is a mutation or a change in that patient. We want to test all of their close family members. We often call them first-degree relatives. So we're talking about parents. We know they inherited it from one parent or the other. We can sometimes guess based on that family history that we've collected, but not always. So we'll start with one of the parents, any siblings that they have. Each sibling has that 50% risk to have that same change or mutation. And then depending on how old their children are, usually in adulthood, we'll also recommend testing for their children as well. And the benefit of testing those family members is that we can do screening for them proactively. We might even do proactive surgeries to help reduce that risk for cancer for them, or even prevent it, depending on what options we have and what cancers we're talking about.
That's cool. Could you discuss any current advancements in genetic and somatic testing related to a cancer diagnosis?
I think at this point, Dr. Hackney was really thorough, and we are just trying to do research at this point. We've got some basics. We've got some things that we know absolutely will help with treatments like BRCA1 and 2 and PARP inhibitors, but we are slowly trying to figure out what mutations are going to lead us to the best treatment. And that's going to change over time as we get more patients into clinical trials, as they start getting those results. And we also are starting to learn with germline or those hereditary cancer conditions, all of those genes are supposed to be protecting us from cancer. And if you have a mutation in one, it's not doing its job the way it's supposed to. And we're realizing that if we can target those pathways that already aren't functioning particularly well, they can give us better treatments that are going to be personalized to that patient, which is phenomenal, but we have to understand and get the right treatments for them. And so it's just going to take us time. And I'm also going to continue to plug clinical trials, as Dr. Hackney said, because that is what's really going to get us there. Patients being really brave and signing on to PARP inhibitor studies. When we were guessing based on how well they did in ovarian cancer trials that this would also do well in breast cancer, that's how we're going to move forward as well in those.
Could you share a bit about what options a patient would have following their genetic testing results, and if and how often you should get retested?
Yeah, so depending on the genetic testing result, it could change their surgery. Absolutely. It can change, as I said before, their screening for other cancers. If it's BRCA1 and 2, it might give us an additional treatment option with PARP inhibitors, depending on everything else that's going on in their cancer. And as you said, things have changed over the past 20 years. And so the testing we did 20 years ago is very, very different. And so we try to encourage patients to keep in contact with a doctor that did their genetic testing, whether it's a genetic counselor or a physician, to keep in contact with them and retest about every 5 years or so, and get those additional genes that we may not have known about, to get that updated information that may have changed. Even from the past 2 years, I know we have added even just like parts of genes that we've realized needed better coverage or have very specific ways that we need to test them. So there's always things changing. And so we may not have new genes, but we may have new technology. And so about every 5 years or so is what we recommend. But that can be very personalized to the patient and the family history that's in front of us and what may have changed within even the last year.
Awesome. Well, I'll put 5 years on my calendar. Thank you, Sarah. Next up in our panelists is Dr. Eric Michael Jablanca from North Beach Plastic Surgery. He's a plastic and reconstructive microsurgeon specializing in fat transfer breast augmentation and looks to provide his patients with the best reconstruction options. Welcome, Dr. Jablanca.
And I'm not sure if he is on yet. I'm emailing his assistant. So what we're going to do is we're going to move over to Dr. Wilson, and
I'm
I'm
so
waiting.
sorry.
Yeah, no, that's okay. You didn't know that. And I'm waiting to hear back from her. Thank you.
Okay. Got that. Welcome, Dr. Wilson. He's the medical director of oncology for Sentara and believes that patients need to feel that their doctor is a good fit. He doesn't feel like if you don't feel like you have a good fit, consider meeting another doctor. It's important that you're comfortable with the providers that you care for. I think that is great. Welcome, Dr. Wilson.
Thank you.
As our discussion relates to social detriments of health and breast cancer, could you first define social detriments of health and discuss the overall connection to breast cancer?
I will be happy to. Thank you for inviting me to participate tonight. I will say maybe next time I can get a topic that's closer to surgery, but that's all right. I'm happy to talk about social determinants of health. Social determinants of health have really gotten a lot of emphasis in the last few years. These are kind of all the things that we think about that maybe more indirectly impact our health. So these are things like income level. These are things like race. They're like living in a rural community versus living in a big urban center. It's things like accessibility to transportation. It's things like education level. It's all these other things that we haven't maybe traditionally thought about, where we've always thought about genetics and we've always thought about, and we've thought a little bit about environment related to cancer. These are some of the other things that really do impact the likelihood of developing cancer and really impact one's journey through cancer. And so those are kind of the things that we think about with social determinants of health. And there's really been an increased emphasis on this recently. I was happy to write something for the guidebook for it and to talk about it. One of the roles that I've played in the last 2 years, I've been pretty active in the American College of Surgeons, particularly within the Commission on Cancer. The Commission on Cancer is this very large multi-specialty group that was started over 100 years ago with the American College of Surgeons with the whole purpose to improve cancer care in the United States. And they do that in a number of ways. One, they collect a lot of data about patients, and that data is accessible for people that are interested in clinical trials. But the part that has impacted me the most is that they accredit our cancer programs. So they put out standards that high quality cancer programs have to meet to be accredited. So for Sentara, and particularly on the peninsula for the Sentara Careplex, specifically where I work, we're accredited as a cancer program, which we are as a system, but we're also an accredited breast program, as is Sentara Williamsburg. And then we also have a rectal cancer program. And so the Commission on Cancer has been hugely important in establishing what makes a good cancer program. And there are a lot of things that go into that. And I say all that to say that the Commission on Cancer is kind of in the midst of surveying their 1,000+ sites nationally about social determinants of health. They want to know what kind of screening exists at various sites. They want to know what are the barriers that patients have to being able to get treatment that they need or to getting diagnosed. What are places doing about it? What kind of things are out there that might be impactful? What other things that are out there that might be helpful for that? And for them to do that kind of at a national level, I think is hugely helpful, in part because if there's a place that has some part of it figured out in California and they've got it figured out, then maybe that's something that we can bring to here. And so it's great to have best practices from across the United States to be able to really start looking at these social determinants of health.
Definitely. Could you further discuss race in relation to breast cancer diagnosis, treatment, and overall survival rates?
Yeah, in terms of diagnosis, and this data is all pretty publicly available, although it always lags a few years. But the Virginia Department of Health has a great place that you can go and look at the incidence of breast cancer in the state, as well as by race. Now it really only breaks it down into black and white. But you can even look by, it's not exactly county, but their health districts, and you can look at it geographically. For the state overall, the incidence is about what it is nationally. But if you look at it by race, Black women have a higher incidence compared to white women. The mortality, like the chance of dying from breast cancer, is really about the same in Virginia as it is nationally. But for Black women, it is higher than it is for white women. Black women tend to develop breast cancers a little bit younger. So the median age for all women is around 64. For Black women, it's about 60. So it does tend to happen earlier. And they're more likely to develop more aggressive triple negative breast cancers. It's been discussed earlier. They're more prone and more likely to develop those types of breast cancer.
Could you share the potential impacts of these social determinants of health on timely and effective access to diagnostic treatment and psychosocial supports?
I can. It's been mentioned earlier, when you get this diagnosis, it feels like life stops, but it doesn't, right? You were 6 months pregnant. People have families, they have kids, depending on how old they are, they have young kids, or They have, you may have parents that are getting older, so all the things of life continue to go on around you and around your diagnosis. So for some women that may be just trying to make ends meet, just trying to make sure the bills are paid, it's easy for me to say, hey, you need to go get this test, and that test is at 2 o'clock on a Wednesday. But if they have to miss work, that's a paycheck that may not be as complete, and that may be money that they need. So all of those things make this so much more difficult. And I'm like I say, I'm really happy that we're starting to think about how can we navigate around these things, because I've definitely had patients tell me that I can't make it on that day because of this, or I can't go see, let's say there's a couple of options for plastic surgeon. I can't go to that particular one because that's just too far, and I can't accommodate that into my day. So all of those things are hugely important. And this is also another place where I will plug the great work that Here for the Girls does. And I was so happy to hear at the Pink Carpet Gala that that one of the next phases, one of the next projects is to look at, hey, how can we do in-person counseling? Because I think that is super important. This is a journey, right? I always tell patients, like, I may have this conversation several times a day. My hope and prayer for you is that you have it once, but it's a big deal for you because hopefully it's that one time. And so I think having that kind of counseling, having resources available is just hugely important.
Yeah, thank you for that. Thank you, Dr. Wilson. So Chris, that is the finale of our attending panelists. What do you want to do now?
I don't believe that Dr. Jablonko is going to be able to join us. If he comes on, then we'll certainly welcome him back in. But I do tell you, we have a number of questions that have been flying in. I've got some on my phone. I have some in the chat. So I thought we would do this. Let's go question by question, and we just open up to anyone. If it please, all of you chime in and come in together. It's always great to hear different perspectives, and it's because it makes such an impact, and it gives different sides to things. So I invite you to chime in if you would like to. So the first question. Well, first she says, thank you so much. And then she says, I'm wondering if someone could speak to post-traumatic symptoms in cancer patients and what measures are currently in place and offered at your treatment facilities to identify and treat these symptoms.
Well, I'll jump in on that one for VCU Massey. I think one of the things that is required, and Dr. Wilson spoke to this, is the Commission on Cancer is asking for us to do psychosocial distress screening and use that as a tool to identify who might need additional services. And depending on the facility, it's done either first visit, multiple visits later. But I know one of the things that we have developed is a survivorship clinic. And I think somebody else here can probably speak to that. Dr. Stefan can probably speak to that too. Looking particularly at long-term issues with patients and trying to see if we can find appropriate counseling, find what the needs are. I think the hardest thing right now, particularly in this post-COVID world, is finding enough mental health counselors. And we could double the amount we have, and we probably wouldn't have enough. But looking for programs that have long-term survivorship, asking for help, I think it's a big one. We have chaplain services that help with the spiritual support, as well as trying to find people who can help with some of the other traumatic issues.
Thank you, Dr. Hackney. Does anyone else want to chime in on the question?
Sure. So at our facility, we do something similar every single time someone comes in. We have them do a depression score. And so if they meet certain metrics, we then talk to them directly and then also make a referral. But you're right, it's been very difficult to have that in time, in person type of counseling available, but we certainly try. And then one of the things I find is that I feel like a lot of the times when patients come in and they get this diagnosis, they're in this fight or flight mode. They know, I'm in the fight for my life. I'm going to do what's required of me. It's this, I'm just going to just take the brunt of it. And I feel like it's towards the very end, once they're finally on the hormone pill or just in surveillance, that they take a step back and are finally able to take that step back to say, what just happened to me? And they're finally starting to process everything. And that's when they say, were the side effects worth it? What did I have? Why did I do this treatment? How has this impacted my life? That a lot of the times now they start to process everything. And that's when we start to see that. So that's where I think the survivorship clinic makes a lot of sense. We can then start to address all of that and start to address all those side effects that come as an aftermath from all the treatment that they did.
Wonderful, thank you. And anyone else want to chime in?
I would second what Dr. Hepburn says. It's often months later that patients, and not only are they beginning to process everything, but they're also in a phase of treatment where their support system feels like you're done with treatment. You should be fine now. And many times they're still dealing with a lot of the after effects. And it's not necessarily the case that they're just fine mentally or physically. So, we also do the distress screening. We've been able to tap into some of the resources for patients with really severe symptoms at the Behavioral Health Center. They've got an emergency room now for behavioral health, which is wonderful. So that's been helpful for patients who are really struggling. So
Thank you. Thank you. Anne, I didn't know if you wanted to chime in. You're welcome to, or during any of this discussion, as you're speaking on behalf of many of your sisters.
Yeah, the only thing I have to say is, everything that the doctors have said has been my experience as well, where, I felt like in the beginning of treatment, I was on a train and I was surrounded by all these people, all these personal people. And I also had, different doctor's appointments every week. And now 3 years out, it's like, they fall off, they fall off, they fall off. And, and I'm, in therapy, so, and, I think that it's, and I'm lucky to have those, social determinants that, I have access to those things. I have, good health. I have the kind of health insurance I can get therapy. It's not that big a deal. And, so I just think that it's important to extend that to everybody. I hope everybody can get that because it still feels like a whirlwind sometimes.
Absolutely. Absolutely. Go ahead, Dr. Wilson.
I was gonna say, also in addition to the mental component of it, certainly our treatments do have physical effects as well. So for surgery, I always think a lot about lymphedema, swelling of the arm that women can get after having had their nodes either surgically removed or surgically sampled, made worse if one requires chemotherapy and or radiation. And the comments I would make about that is, one, the best thing we can do is to try to prevent it. So, most people don't need to have all their lymph nodes taken out in 2024. It's become less and less common, fortunately, because the best thing I can do is prevent it from happening. And then, two is, this earlier we can intervene. So if there's any question about arm swelling or arm doesn't feel right, the sooner we can get people to physical therapy, get them sleeves, get them compression, etc., the better people tend to do with that. So I think being aware and making sure if there's something that doesn't seem right or that has changed, to make sure you point it out to your surgeon or oncologist.
Thank you, Dr. Wilson, and thank you for mentioning about the Here for the Girls counseling that's being launched, and we're there to offer the little bit that we're able to do. All of us need to come together, so we will definitely tap into the expertise that all of you have. I would like to ask a question before I go into the next one. Is this survivorship clinic? If you can speak a little bit more to that, Dr. Hackney and Dr. Steffen, I know that a number of members are asking about this, and to see what does it look like, how do they get involved, especially those that have been, a number of years out. What exactly, what's offered there? And if you're a number of years out, can you then get involved?
So I can speak for ours. Ours is survivorship clinic is run by an internal medicine physician with a team of nurse practitioners, and they are focused on sort of wellness now and wellness in the future. Are you keeping up with your other cancer screenings? Do you have a side effect, long-term side effect that needs to be managed? So that is sort of their focus as to where you are now, what are possible consequences you might have had in the past, consequences that we need to look towards the future. So that's their big focus. And it can be things like neuropathy. It can be things like, are you at higher risk for cardiac issues? The mental health issues, obesity issues. Sometimes it's a bridge to finding a good primary care, but it's really sort of a wellness drive is the focus. So.
Perfect. Thank you. And I love that, the bridge to the primary care. Thank you for adding that. Dr. Steffen, did you want to add to that?
Well, I would aspire to that goal of being able to have a team who does just survivorship. So for now, on the medical oncology side for our health system, the medical oncologist and nurse practitioners primarily doing the survivorship. So I see everyone who completes radiation. And so for some of those patients, I continue to see them for years because they aren't seeing another provider if they didn't require chemo. So for some of the things we treat, they don't have a medical oncologist. Prostate cancers, head and neck cancers sometimes. So, but then for patients who do have other providers, and we mentioned the bridge to primary care, we'll make sure that they've recovered from effects of the treatment with us, and then, have them primarily follow up with either their medical oncologist or PCP. But I know we do a Virginia Survivorship Consortium, and the head of the program there at VCU is very active in that, and it's kind of a model that would be wonderful to be able to have that kind of comprehensive care that they have in the clinic there. Yeah.
So let me make another comment real quick about when we're looking at survivorship, and somebody in one of the questions was asking about conditions after treatment. And I think all of us have taken care of patients who have different things. That's another great group of clinical trial work. We have 3 cardiologists at VCU who focus on cardiac issues during and after cancer treatment. And some of those are long-term follow-up issues with cardiac disease. There's a physician a team out of UVA that is running a trial on sexual issues after breast cancer. And I know we all have heard about sexual issues after breast cancer. They have almost recruited for the trial as it is now, but they're going to be coming up with trial number 2, looking at assessment of sexual problems, sexual health and intimacy, the SHINE trial, SHINE, open at many sites. So there is, I don't know that we have it open now. They're looking at neuropathy, but that's been a common complaint. So when we think of trials and making advancements, it's beyond just the actual treatment, but can happen, after when you're into that survivorship mode.
There are huge opportunities for research in that realm, without a doubt.
Thank you for sharing that information. I'm going to go on to the next question because they're just kind of coming in here. How can someone adequately advocate for themselves after treatment regarding conditions that may arise? A host of conditions are not frequently discussed, As patients, we are often in a reactive posture once we are later diagnosed with a condition that resulted from treatment. How can we be proactive, and should we advocate for more screening to address these concerns? It looks like Dr. Hepburn, do you want me to read that question? Do you want me to read the question
I'm
again?
trying to see how I could best answer that. And I'm trying to say, I guess, well, one, I would hope that someone is comfortable enough to just be able to tell us what type of side effects they're having. I think that's the very first thing, is really being able to have a good team where you feel comfortable bringing up side effects so that we can address them in a timely fashion. For instance, the one about peripheral neuropathy, it's something that builds over time. But if it's not something we don't know about, then it's something that's just going to progressively get worse. And sometimes even when someone brings it up and they're saying, well, now I'm having balance issues, at that point it might be a little too late, just because it's one of those things that it's supposed to be a reversible effect when we stop it, but for some people it just never really fully corrects 100%. So as Dr. Wilson said, the earlier we know about something, the quicker we can respond to that. And I think that we know the typical types of side effects for most cancer drugs that we're giving, and so those are the ones that we usually bring up. But what I find that is helpful to kind of target when someone comes into our clinic appointment, because I know I'm not alone in that, we have these 15, 20, 30-minute appointment slots, and there are a lot of questions that come up. It's helpful for me when patients come in with a set of questions, so that when I come in, I know, there's always things that I want to go over, but I want to make sure that I address those questions. So I start with those questions. If someone brings them in, and that way I know I've addressed their concerns first, and then I can bring up other things that maybe something's abnormal in a lab or something else. But at least that way I know. And so it's just important to write things down for the patient so that they know that their stuff is addressed, and so that they don't forget, especially chemo brain and all. That can happen sometimes, but it just helps me with the planning going forward too.
I think sometimes, Dr. Hepburn, that patients don't know actually what questions they should be asking. And there are situations that we have, or we've seen different experiences where something else has come up, possibly another diagnosis not related to breast cancer, that they may not be aware of. And I believe maybe that's where the question is going. Possibly should there be screenings for other things? And they're just not sure sometimes what questions to ask. And I don't know if there's any kind of guidance there, or, how do you advocate for that? Dr. Hackney?
Yeah, I think, one thing is to look, there are some resources, cancer.net, which is now merged with ACS a little bit, used to have a list of questions to bring to your doctor, or concerns to, if you see this, bring it up with your physician. And although it's fairly general, I think it does give people a little bit of a foundation of, this is a little bit, maybe I do need to bring this up. And I used to direct a lot of patients to cancer.net website for that very reason of, they had a survivorship section, when to call your doctor is what they called it, I think. So I just haven't looked at it lately. But that can be a
Thank you
tool.
for that. I thank you for that. I wrote that down.
Yeah, I as I said, double check it. I just haven't looked at the tool lately.
Perfect. Anyone else wanted, Dr. Hepburn, did you want to say so? I don't, you went off.
I'm trying to make the most sense of that question. And I think that it's just, there are multiple questions that come up at each stage of the cancer journey. I feel like at the very beginning, it's always, what questions do you ask? And that's when people come in with, what stage, what are we going for cure? Is this something that's palliative? What treatment options do I have? It's a whole slew of questions. When they're going through treatments, it's, are there other things that I could be doing to help with my health, to help prevent this, to help with the toxicities? And then afterwards, in the survivorship mode, it's a lot of the, if I have back pain, should I tell you, or should I tell my PCP, that kind of thing. And so it's just a different set of questions at each time point in the journey. And certainly it can be difficult. And I think a lot of the times we do end up being the primary care because we say, come to us to tell us about most of what's going on so that we can help. Because sometimes even the PCP feels uncomfortable. And so it's hard, but I think there's no easy answer to this. I think that I hope that along the way we can come up with questions together. And I think a lot of it is very personalized because each person's cancer journey and side effect profile from the treatments is very different. So I think that having a team of people with nurse navigators and the palliative care people, social workers, and everyone coming together to hopefully help answer their questions along the way, not just one time point, will be helpful.
That really helps, and I think that there's, sometimes they're just scared, they're afraid. But just kind of having a night like this, and all of you are so comfortable to talk with, it removes a lot of those barriers and fear of approaching. And the information that you're offering is really helpful. So thank you. I'm going to go into the next question. Could someone share why they believe there are not trials related to the prevention of recurrence following initial treatment and excluding hormonal treatments? For example, long-term medications that can work to enhance the immune system's ability to inhibit recurrence. These aren't just simple questions. I think that they came prepared.
Yeah, well, I think one of the challenges is that breast cancer is not a very immunogenic cancer. And so that's why we've had a hard time finding immunotherapies to fight it. And that may, if we extrapolate from that, may be why we can't get the body to fight it earlier by, how do you define your immune system? What do you make doing your immune system to make it fight the cancer? But your body's got to recognize that it's abnormal. That's, immunogenic, something that stimulates a response from the body. And breast cancer doesn't do it so well. Some other cancers do, melanoma, renal cell. That's why there are a lot of immunotherapies that fight those cancers. So I think that
makes a lot of sense.
I think it's a great thought that, we should be able to fight it, but we've had a hard time with breast and pancreatic particularly. So,
thank you, Dr. Hackney. Does anyone else want to chime in on that? That was helpful. Thank you. The next question is, have there been any advancements in the ability to detect a cancer recurrence at an earlier stage? So, for instance, a blood test or any types of testing?
There isn't anything specific. I think a lot of us sometimes use the breast cancer tumor markers that are available, but they're not specific either. There's just one other point of information. And if we start to see a trend up, it gives us more of a reason to do imaging sooner rather than later, but it's not perfect. And I think as of now, that's the main thing. And we have to weigh the risks and balance between the toxicity that you can get from radiation if we're constantly doing imaging, because that's not always perfect either. But I think lab work with that tumor marker testing is what we could do for early stage breast cancer.
Thank you. The next question is, this individual would appreciate learning more about the success rate of reconstruction surgery years after receiving radiation. Which surgical procedures would you recommend if someone was interested in reconstruction years following treatment? And I know that Dr. Jablonka is not on, but I didn't know if anyone can address the reconstruction question.
I will be glad to answer with the caveat that I am not a plastic surgeon, but certainly this does come up a fair amount. Certainly radiation does make it harder. The thing that's a challenge about this question is the answer is that it depends. So it depends on one, how long it's been since the radiation. Two, it also depends on how well someone recovered, because everybody's so different, right? So, some people, you look at them like 2 years later and you're like, are you sure you had radiation? And then eventually you find that they had like a little tattoo, and okay, I guess you did. And then some people, you can always tell pretty easily that, okay, that side got radiated. So everybody just heals so different. I mean, the short answer is that the history of radiation is going to increase the risk of doing surgery in that location. And it very much depends on plastic surgeons. I've worked with plastic surgeons that were pretty adamant that if you had radiation, that you'd be best served with a flap where the plastic surgeon uses your own tissue and moves it around. But depending on how long it is, I've had plastic surgeons that were perfectly fine doing tissue expander or implant-based reconstructions afterwards, but always telling people that, you know, the risk is going to be higher. And I'm not going to put a number out there because I'm less good with that literature than the primary surgery literature.
Thank you. I appreciate that answer. Actually, that's what Dr. Jablonka was going to talk about. So possibly he'll maybe jump on in a few minutes. I'm not quite sure. I do have a couple of other questions that were sent via text. This one is for Sarah, for genetic testing. What is the earliest age to test someone for the genes?
So most of the hereditary cancer genes, they're not going to have any cancer risks until adulthood. So we would say somewhere around 18. Many of them don't have screening until 25 or 30. So we'd recommend testing somewhere in that stage of 18 to 25. I know I've seen patients where they said I would be anxious the entire time. I don't want to test until there's something I can do about it. So they wait till they're nearly to that 25, 30 range. And I've had some say, I want to know immediately, and they taste at 18. There are some genes like TP53, APC, where there are childhood risks associated with them. If it is one of those genes, then we test at the time we would start any sort of screening for that patient.
Okay, perfect. Thank you. And this next question is titled hormones. And the question is, what role do hormones or birth control play in a cancer diagnosis? Dr. Hackney?
Birth control, oral contraceptives, the data is very limited in terms of increasing risk of breast cancer. The way I tend to think of it is that most people who are using birth control are young women who fundamentally have a lower risk of getting breast cancer just due to their youth. So there hasn't been a clear increased incidence of OCPs increasing the risk of breast cancer. I think most oncologists, and I'll look at my colleagues on the screen here, do not recommend using OCPs after a diagnosis of breast cancer because we are concerned a little bit about adding that extra hormonal stimulation. Hormones for menopausal women to help hot flashes and the symptoms of menopause has been very controversial. I think many people still believe that if you are on hormone replacement for, depends on who you read, more than 5 or 10 years, your risk of breast cancer might go up. Although that data is being sliced and diced again in terms of how valid it is. But I think long-term replacement of hormonal therapy of hormones may be worrisome. We certainly have seen a decline in cancer occurrences in women over 50 that coincided with less hormone replacement. So there is this balancing act about, can you manage the side effects of menopause versus taking a pill that might have some increased risk? Dr. Hepburn, you want to holler in on that one too?
No, I would say the same thing. I think that certainly hormone replacement that used to be given before probably 10, 15 years ago had much higher estrogen. And so we were then started to see a lot more breast cancer occurrences. Certainly now, if someone comes in and they're ERPR positive, we tell them to stop the estrogen if they are on any, including birth control. We usually say either condom use or some sort of like a copper IUD is best. And then after the fact too, in trying to help with some of the side effects, luckily there's a new drug on the market now. Hopefully it'll eventually be more affordable, but currently it's called Veoza, and it's not estrogen based, and that's supposed to help with some of the hot flushes that people can have. Venlafaxine is another one. There's a lot of stuff over the counter that may or may not work, but usually we try to say, try water-based lubricants first, coconut oil, vitamin E capsules, avoid estrogen if you can, especially if you're ERPR positive. And we coach people through that depending on how old they are and how close they are to their diagnosis.
Wow, that's really helpful. That's helpful information. So before I turn it, I come to the closing remarks. I didn't know, Anne, did you have any other follow-up questions, or anyone in the audience that are on the attendees? Did you have any other questions? And I'll just kind of give it a moment.
Well, I'm never going to turn down an opportunity to ask some breast cancer brain trust about chemo brain, something that really affects me. I was pretty high functioning. Then I became a cancer patient and a mom and turned 40 all in 3 years. And I just, the feedback I get from my providers is, journal more, write it down, these very like practical, simple things. And I've run across like a few, I wouldn't say like studies, like I would read a study, but I've like, blurbs about like using stimulants, like they use like Adderall and stuff for people with chemo brain. Has anybody heard that? Or is there any study I can get in to fix my chemo brain? No? Okay. Cool.
Not aware of any particular one. I think that what you're saying is generally what we recommend is, short-term recall, doing all those mind games to help rebuild all of that. I do feel like sometimes we do short courses of Adderall for some patients if they really are struggling and they feel like they need that. But usually in conjunction with psychiatry and all of that too, to help balance out some of those side effects. But there's no good treatment option as of now that I'm aware of anyway.
Okay. Thank you.
Just in survivorship, I've certainly had patients who are on Adderall for other reasons, and I think they still experience that same fog. I don't know that it's significantly helpful, and I'm definitely not aware of any data that it would be. So I've had a personal experience with cancer as well, and I found afterwards, and 8 years now out, but it seems to be more focus and concentration. So I think just changing the way that you approach tasks sometimes. I could do 50 things at once beforehand, or at least I thought I could, and really focusing on the task at hand, being a little bit more organized about the way I approach things. All of those things I think were really kind of helpful in not correcting it, but coping with the change, if that makes sense.
It does. Thank you.
Yeah.
Wow, thank you so much. And Dr. Wilson, thank you for putting that in the chat. This was amazing. I'm so glad that we hit record, because this was just chock full of information and really helpful advice. I thank all of you. I have a question, a favor actually. On our website, and this is to the audience as well, we have a page that's dedicated to the In the Know. It shows all of the physicians and presenters that are on the call tonight. It links everyone to their particular site. So please, I invite our audience to go on and check it out. There's a lot of great information that each of these sites has. And to the presenters, you have offered a lot of information. I'm going to reach out and just double check on a couple of things. I have this cancer.net. Thank you for the book, Dr. Wilson. And you also mentioned a number of clinical trials. I'd like to get maybe a list of that. And my thought is to just kind of add it to the In the Know, because this is a recording. So what we'll do is we'll link it back to the recording, and we can link it back then to this homepage, so that those people who are not able to join us can hop on and then have, some sort of a resource. Does any of the presenters or physicians, would you like to add one more thought, comment? I invite you to do that.
Just thank you for having us.
Yeah,
Oh,
thank you.
Absolutely.
I can't thank you enough. This is just fantastic. Really, really appreciate it. And to have all of you from all the different parts of our Hampton Roads really makes a difference. And we're very, very appreciative. So on behalf of our board of directors, our staff, and of course our members, a huge thank you for taking the
Yeah.
time. Yep.
Thank you.
Have a great night.
Thanks.
Bye-bye.
Good night, all.
Good
Good
night.
night.